I'm talking to Mr. Harry Brownlow about frozen shoulder. Harry is a shoulder and elbow specialist in Berkshire who'll be answering questions about what to expect if you have a frozen shoulder. Hello, Harry.
Hello.
So the first question I've got for you is, what is a frozen shoulder?
Well, a frozen shoulder is an odd condition and one that's very common, but not one that we understand a great deal about. And what we do know is that there's two components to having a frozen shoulder. One is that the lining of the shoulder joint becomes intensively and aggressively inflamed, and it is that that's responsible for the pain that you get. And the second aspect is the capsule, which is the bag that contains the shoulder, should be loose and capacious and allow for the lovely movement that most of us have within the shoulder. But in this condition, it becomes thick and tight and contracted and causes a physical restriction to the amount of movement that you have.
And what causes a frozen shoulder?
Well, in many cases, we don't know. A genuine frozen shoulder usually comes on out of the blue for no very good reason. If you're diabetic, however, you are more likely to get a frozen shoulder than if you are not diabetic. And if you're diabetic, the version of frozen shoulder that you get is also worse than it is for other people.
So saying it's worse with diabetics, does that mean I might have diabetes if I'm told I've got a frozen shoulder?
No, I think that's the wrong way round of looking at it. If you have diabetes and you will know that you have diabetes, then you are at risk of developing frozen shoulder. But I've never diagnosed someone as having diabetes simply on the fact that they have a frozen shoulder. I think it's something that comes on at a later point within the disease process.
Okay, so what can one do about it? How do we treat it?
Well, I always say there are three ways we can treat it. You can either leave it and wait for it to get better naturally. It's surprising to believe that it might happen, but it does. It's slow and painful and stiff, but even so, it will get better. And if we abandon you on a desert island and come back in 18 months, in most cases your shoulder will be completely normal. You'd have no pain and full movement and no long-term repercussions. So option one is to live with it, put up with it, accept it for what it is. Option two would be to have a cortisone injection administered into the shoulder joint, and that's very good for relieving pain, but does nothing to help improve movement. So it would still be a matter of waiting for the movement to get better naturally. And there is a third option, which is a minor procedure, what we call a manipulation under anaesthetic, whereby we stretch the shoulder and recover the movement, and while you're asleep also inject you to manage the pain.
So if I were to choose just to have the injection, if actually I thought if I could just help with the pain and get through that and wait for the movement to recover, how long would that injection last and how is the injection done?
Yeah, so the injection has to be put in exactly the right place, and the injection has to be administered into the glenohumeral joint, which is not where most people have shoulder injections administered. So we use ultrasound and we do it ourselves to make sure the injection is given into exactly the right spot. And within a week, most of your pain should have gone, and you will sleep better and be able to do the kind of things that you want to do without pain, albeit you will still be stiff. Now, how long will it last is always a good question. In my experience, most people would only need one injection for this condition. Very occasionally, a second one might be required. And
it's okay to have more than one injection? I know people worry about having lots of cortisone injections.
Yeah, they do. The current recommendations is that you should not have more than 2 or 3 injections per site per year. So we would never give more than that.
And with the procedure that you talked about, the anaesthetic, manipulation on anaesthetic, are there any risks or things people should be worried about if they went for that option?
Yes, and it's always an important question to ask. The major risk is the operation may not work. We know it's successful in 90% of people, but that does mean in 10% of people, or 1 in 10, it hasn't worked. And what I mean by that is that after a month or so, you will be back to square one. Your shoulder will be just as painful and just as stiff as it was before the operation. And if you are that unlucky 1 in 10, the procedure can be repeated with the same success rate of 90%. So that's the commonest complication. Other complications that we are obliged to mention because they are important are actually very rare. So, for example, it is possible that in the process of manipulating your arm, I might break a bone. I'm not aware I've ever done such a thing, but I suppose it is possible. Similarly, we might cause a shoulder dislocation. That does sometimes happen, but of course I know I've dislocated your shoulder and I pop it straight back into joint, and it does not seem to cause any long-term consequences whatsoever. And the third major complication that we will be obliged to mention to you is the possibility of nerve damage in the arm, which may even be permanent. Now again, in the many hundreds of times I've done this operation, I've never encountered that, although it has been described in the literature, and therefore we are obliged to mention it.
Okay. And following the procedure, how quickly would I be able to get back to work, back to driving? What's the expected recovery?
Well, the first week is often quite tough going. You will have pain, and I will expect you to be doing a lot of exercises and stretching, trying and working hard to maintain your newly recovered movement. So most people would not be driving for the first week, and if you need to be able to drive to work, then you would expect to have at least a week off work. After that first week, most people feel fairly comfortable about driving and fairly comfortable about returning to a sedentary type job. However, if your job requires a lot of overhead physical activity, for example, it may be several weeks before you feel really ready to return.
Okay. And are there any other, when you say it gets better anyway, why do people then choose to have the procedure?
So in my experience, people fall fairly neatly into three categories. There are those who philosophically object to having a procedure performed for a condition that they know is going to get better, and really they just need to understand what the condition is, have a clear diagnosis, and then they are prepared just to put up with the troubles, and that's a perfectly legitimate way to manage it. There's another group of patients, and this is probably the majority, who feel that as long as the pain was managed, and in particular the night pain was managed, they could put up with the condition, again confident in time that it will get better. But there's a third group for whom the lack of movement is a major problem, and in my experience that's very typically a sporty person when the condition is affecting their dominant arm. And if returning to tennis, for example, is an important part of what makes you happy and makes your life tick, then having a manipulation is the quickest and most reliable way of getting you back to playing your sport as quickly as possible.
Okay. So if I think I might have a frozen shoulder and I come to see you in clinic, how would you confirm that that's what the problem is? How would you diagnose that is what I've got?
So the diagnosis would start with the history, and there are some very key features of the history which signify a frozen shoulder over any other shoulder condition. And those are namely the pain. So the character of the pain is very typically a constant, low, dull background ache, which actually is quite and perfectly manageable. But it's sharp, quick, unguarded movements, such as being yanked by the child, or the dog takes off on the lead unexpectedly, or you reach out to stop something falling, or you swat a fly. It's those kind of abrupt, unthought out movements which cause a really nasty wave of pain running down your arm that lasts for a minute or two and then recovers, and then you can move on. And night pain, again, is a very classic characteristic feature of frozen shoulder. The other aspect is I would expect you to tell me that you feel like you've lost movement, and in particular people seem to notice that when reaching up their back, either to get their wallet out their back pocket or to reach up to their bra.
Are there any special tests or scans I will need to have for the diagnosis?
Well, in terms of tests, I would do a clinical examination, and I would expect to find that you have a reduced range of movement in multiple directions, but you maintain good strength, and all that would be characteristic of a frozen shoulder. I would generally expect you to have an X-ray, and that's just to rule out the other potential diagnosis, which is of osteoarthritic changes within the shoulder joint. But I would not expect you to require any further investigations. In particular, an MRI scan is surprisingly unhelpful because there are no characteristic features seen on an MRI scan which indicate the diagnosis of frozen shoulder.
And if I thought, okay, that's fine, you've told me it's going to get better, great, I'm just going to sit it out for a year, 18 months, wouldn't physiotherapy be helpful?
No, actually, this is one of the few conditions in the shoulder where physiotherapy does not seem to help, and indeed can make it worse. And a good physiotherapist will recognise that she is not making progress with you, and that the shoulder seems to be getting worse rather than better, and stop at that point. And I would suggest to you, if you're taking the route of non-intrusive therapy, that I would not do any physiotherapy. I wouldn't do any formal stretching program. I wouldn't go to the gym and stretch it out. You can continue doing Pilates or yoga, but don't try and push your shoulder beyond its comfortable boundaries. You're simply giving yourself unnecessary pain.
Brilliant, thank you.